So thank you everyone for joining us and welcome to the Peggy Lillis Foundation for C. diff Education and Advocacy's 6th Annual Advocacy Summit and our second virtual one. The past year has been incredibly trying for our country and the world. I didn't imagine when we met last year, about 3 months into the COVID-19 pandemic, that we would all still be wearing masks and socially distancing. However, there has been an enormous amount of progress, thanks in large part to the infectious disease experts like those we have with us at the summit. With over 65 million Americans now fully vaccinated, the future is brighter than it seemed even a few weeks ago. Still, over the past year, we have seen the weaknesses of our public health infrastructure and our healthcare systems laid bare. Weaknesses that are the result of more than 40 years of disinvestment in public health at the local and federal level, particularly with respect to infectious disease. We're going to talk a lot about that today and on Thursday. But the pandemic has also brought out the best in doctors, nurses, pharmaceutical companies, and other healthcare professionals, many of whom became infected with COVID-19 and too many of whom have perished. We have also seen essential workers from the Postal Service to plumbers, electricians, teachers, grocery store workers, food delivery workers, and so many others step up and put themselves at risk to keep our country running. Many of the presenters of this year's summit have spent the past 15 months fighting COVID-19 as frontline clinicians, as researchers and scientists, as policy experts, and as loved ones caring for someone with COVID. I'm endlessly grateful to them for their hard work and sacrifice to combat the pandemic and for making time to be with us for the summit. 11 years ago today, nearly to the moment, I arrived to take my mother Peggy to a gastroenterology appointment. Because she seemed dehydrated, we elected instead to take her to the emergency room. Later that day, I first heard of C. diff. And despite the best efforts of doctors and nurses at a small hospital in Brooklyn, a little over 36 hours later, she was gone. We swore on April 21st of 2010 that her death would not be in vain. Since then, we've grown the organization founded in her memory to be the preeminent patient advocacy organization combating C. diff infections. Thanks to the generous support of every donor and volunteer, we have kept that promise, and we will continue to. We are incredibly grateful to all the sponsors of this year's summit, including Pfizer, Merck, Seres Therapeutics, BD, Dionov, Vedanta Biosciences, the Pew Charitable Trust, Summit Therapeutics, Devil Terra, and Hill Scientific and Public Affairs. In addition to these generous partners, I want to thank this year's lead sponsor, Ferring Pharmaceuticals. We are delighted to be joined today by Ferring's Vice President of Specialty Care, Lionel Fajol. Lionel is going to join us now to welcome you all to the summit.
Good morning, everyone, and hopefully I'm not on mute, and clearly the voice of the Peggy Lillis Foundation cannot be muted. So my name is Lionel Fajol. I'm the Vice President of the Specialty Care franchise at Ferring Pharmaceuticals. I'm honored to welcome you all here to the Peggy Lillis Foundation's 6th Annual C. diff Advocacy Summit. First and foremost, thank you to Christian Lillis and the organizers of this summit for bringing everyone virtually together and forging ahead with the important work of helping people living with C. difficile infection and their loved ones, persevering even during the COVID-19 pandemic. As we well know, this is a devastating illness and an urgent public health threat that the CDC says requires immediate and urgent action. And we are truly inspired by your commitment to help others better understand the critical need to fight this disease. At Ferring, we wholeheartedly support all that the Peggy Lillis Foundation does for individuals and families impacted by C. diff infection and their loved ones. In addition to the physical toll of this disease, we also understand the severe emotional impact it can have. People who have survived C. diff infection often experience depression, anxiety, and fear of infection recurrence. While C. diff infection can be debilitating both physically and emotionally, we know that the passion and dedication of advocates such as you may help save lives and restore emotional well-being. We're also working diligently to support the community through our ongoing research efforts, and proud to support this amazing organization. Our mission at Ferring is to help people live better lives. Our teams are committed to exploring the crucial link between the gut microbiome and the threat of recurrent C. diff infection. We are rapidly advancing microbiome research and developing novel therapeutics to help address significant unmet needs in deadly and debilitating diseases, starting with recurrent C. difficile infection. We believe that the need for new treatment is urgent, and we are working towards the goal of identifying and bringing to market proven clinical options with a focus on who matters most in this fight: individuals living with C. diff infection and their loved ones. Thank you again for your ongoing service to this community. We are proud to partner with you today and always. Now, please join me back in welcoming back Christian Lillis to begin the summit.
So thank you so much, Lionel, for your gracious words. And we are absolutely thrilled to partner with Ferring, and we're very excited for the new treatments that you guys are working on. And we look forward to patients having a ton more treatment options in the future. So thank you so, so much.
Thank you, Christian.
Thanks again to Lionel and the entire Ferring team. Many of them will be in attendance, and they're just an amazing group of people, and I hope you'll get to meet them during our networking portions. Also, Peggy Lillis Foundation has our own booth there where you can check out our new t-shirts for the summer. So definitely head over. I think you can see that I'm wearing one of them. Oh, actually, there you go. So you can see that I'm wearing one of our I Give a Crap t-shirts, and we want everyone to give a crap about C. diff. So thanks again so much for joining us. I'm going to kick off my keynote presentation in about a minute or so, and we have a really amazing day planned for you. We have speakers covering an advocacy agenda for superbugs. We have a public health and epidemiologist, Greg Gonzalez, speaking about a global health justice movement later. And we're going to have a panel discussion on how we do antibiotic stewardship in order to prevent C. diff infection. So a ton coming up today. Make sure you check that out. Also, at noon, we're going to have a couple of breakout rooms where you can have lunch with one of our advocates. And I'll be there too if you'd like to have lunch with me, and we can have a chat and get to know each other better and answer any questions you have. So stay tuned. I'm going to start my presentation in a moment, and thank you guys so much for being with us. And I think for those of us who have been combating the C. diff pandemic, we've noticed that it disproportionately impacts seniors. So that's what I'm going to focus on today. And I'm going to apologize in advance because apparently they are collecting the garbage outside my window. So my grandmother, Dorothy Daly, died in August 2016 at the age of 93. Though she had struggled with dementia for the last few years of her life, it still felt too soon. Well into her 80s, my grandmother, whom we called Nanny, was a sharp, funny, and loving matriarch of our large Irish Catholic family. Her life was one of immense contribution and devastating losses. She was the mother of 9 children and grandmother of 19. Nanny lived long enough to bury not only most of her contemporaries, but also her husband, 2 younger brothers, and 3 of her adult children, including my mother, Peggy. Still, the last years of her life were filled with the joy of grandchildren's weddings, graduations, and other celebrations of her and my grandfather's legacy. Though Nanny suffered from dementia, that wasn't what killed her. In August 2016, Nanny fell, breaking her hip and wrist. I have worked in healthcare long enough to know that 90-day mortality for someone her age with a broken hip is extremely high. We debated whether to subject her to hip surgery, ultimately deciding it was worth the try. She came through the surgery fine. However, the surgery required that Nanny stop her blood thinners to prevent hemorrhage. After the surgery, she was transferred to a nursing home for rehabilitation. There, Nanny's combination of dementia, broken wrist, and hip made it difficult for her to do physical therapy. Our large family made sure she was rarely alone. Still, we found the quality of care lacking. The facility wasn't sufficiently staffed, so residents were left to sit in wheelchairs around the nursing station for several hours a day. When I objected to this practice, I was told it was common in our nursing homes and that she was in one of the better facilities. Not long after being admitted to the nursing home, my husband and I visited Nanny one evening. She was very agitated, much more than was typical of her dementia. We stayed for as long as we could bear and then texted our family about her condition. The next morning, my Aunt Mary arrived to find Nanny again in her wheelchair lined up with other residents. But she looked very different. One side of her face was slumped and her voice was garbled. It was clear that she had suffered a stroke. When confronted, the staff claimed not to have noticed the change. Nanny was evaluated by a physician who confirmed that she was unlikely to have any meaningful recovery. We moved her to a hospice facility where she died peacefully a few days later. While I was upset about the substandard care that Nanny and her fellow residents received, I wasn't surprised. 6 years earlier, in April of 2010, my mother died from a community-acquired C. diff infection. If you're not familiar with it, C. diff is a bacterium present in the guts of many adults. It can exist among the trillions of other bacteria, viruses, and microorganisms that live in our gastrointestinal system, many of which are beneficial. However, when the balance of our microbiome is disrupted, most often by antibiotics, the C. diff bacteria can grow out of control, leading to diarrhea, fever, nausea, and in the worst cases, potentially deadly inflammation of the colon and sepsis. C. difficile, once considered almost solely a risk to elderly and immune-compromised adults, was allowed to kill with near impunity in many nursing homes until the early 2000s, when it began striking down young, healthy people like my mother. C. diff has killed hundreds of thousands of seniors since it was identified in the 1970s, with little public outcry. And C. diff is only one of several healthcare-associated and increasingly treatment-resistant infections that have been permitted to fester among our elderly population. Increasingly, these infections, like MRSA, CRE, VRE, and many more, are showing up in younger and healthier Americans. So what are the consequences of this? Well, the consequences are that we lost my grandmother, we lost my mother, but the COVID-19 pandemic has ruthlessly exposed what many of us have known for years. Our nursing homes largely fail to protect our seniors from preventable and often deadly infections. Mostly this is permitted because nearly half of the residents do not have living relatives. They don't have anyone to serve as an advocate or report negligent or malicious care. And among those who do, their relatives are often younger, juggling work, family obligations, and a range of other commitments. This makes it very difficult for them to stay on top of facilities to which they have entrusted their loved ones. Throughout the COVID-19 pandemic, I have been horrified by the disposability of our senior citizens. Early on, gut-wrenching headlines of how C. diff was killing our senior citizens at an alarming rate were everywhere. From Forbes, quote, 43% of US deaths are from nursing homes. From the Cleveland Plain Dealer, quote, with 1,442 dead, nursing homes account for 70% of Ohio deaths. The City's headline, hundreds died of COVID at NYC nursing homes with spotless infection inspections, is among the most damning. And my governor, Andrew Cuomo, responded to the shocking failure to protect our elderly by giving immunity to nursing home executives in our state. Executives who are also donors to his campaigns. The legislature has since reversed this immunity, but we're a long way from justice. And for many of us, we have known, at least for the past 20 years, that this was the state of affairs in our nursing homes. Following the publication of To Err is Human by the Institutes of Medicine, clinicians, researchers, and a growing number of patient and caregiver advocates began to focus on the egregious number of healthcare-associated infections in the US. At the time, the Centers for Disease Control estimated that 3.5 million Americans were harmed by a healthcare-associated infection annually, with 42% occurring in long-term care facilities. The report estimated that at least 1/3 of them could be prevented by better infection control procedures. An array of professional societies, nonprofits, and individual patient advocates spent the next decade passing laws to increase surveillance of and accountability for HAIs, including public reporting in many instances. However, these laws often only included big hospitals, acute care facilities, and in doing so, obscured the growth of preventable and often lethal infections among our elderly. More recently, the Centers for Medicare and Medicaid have set rules requiring some reporting from nursing homes, but it remains quite sparse, with only urinary tract infections being mandatorily reported. The rest of the data that we do have is reported voluntarily to the CDC's National Healthcare Safety Network or through state health departments. But the number of infections that are reported and how those infections are reported varies widely from state to state. We now have more than 2 decades of research that show that HAIs and antimicrobial-resistant organisms disproportionately harm and kill our elderly. Yet prior to COVID-19, the media mostly ignored this carnage. When infectious disease outbreaks have captured the media's attention, they are nearly always among young people, like the 2007 outbreak of MRSA in a high school football team in New York. A news search from January 2000 to present revealed no US media reports of C. diff outbreaks. Yet C. diff outbreaks are a frequent occurrence, particularly in nursing homes and long-term care facilities. But with little transparency or interest in the welfare of an aging population, little public attention is paid. This scourge of preventable infections in nursing homes is a long-standing problem. A December 2017 investigation by Kaiser Health News showed that infections like MRSA and C. diff were not only running rampant in our nation's nursing homes, but also that the operators face virtually no penalty for lax infection control. In fact, an analysis of 4 years of federal inspection records shows that 74% of nursing homes have been cited for lapses in infection control, more than any other type of health violation. Despite this abysmal record, these facilities get less than a slap on the wrist from state health departments. Per Kaiser, only 1 of 75 nursing homes found deficient in the 4 years they examined received a high-level penalty that can result in a financial penalty. So sadly, the situation we're in is that the Centers for Medicare and Medicaid, which plays a significant role in regulating all healthcare facilities, including nursing homes, has sat on its hands while residents are harmed and killed by preventable infections. In response to Kaiser's investigation, CMS claimed that most infection control violations had not justified fines because they did not put residents in certain danger. Whether or not an outbreak puts a senior in certain danger is, I think, fairly obvious. And the COVID-19 pandemic has revealed this claim of whether or not an elderly person is in certain danger to be pure pedantry. Imagine arguing that fines for failing to wear a seatbelt were unjustified because it's not certain that your car will crash, or that a vermin-infested restaurant should not be fined because we cannot be certain it will lead to diners becoming ill. What we can be certain of now is that lax infection control allows for a nursing home ecosystem through which COVID-19 has spread like wildfire, killing over 174,000 residents and workers thus far. The death toll has only come down due to the ramp up of vaccination. And that's a good thing. Those of us who have worked in infections have known all along that CMS and state authorities have looked the other way while seniors die needlessly. Kaiser nursed a disturbing example from a Texas nursing home where, quote, inspection records show nurses and aides are often not familiar with basic infection protocols, such as wearing protective clothing when coming into contact with contagious residents, and isolating them from others in the home and from visitors. Others are not trained properly on how to clean patients. Worse, these facilities often fail to provide their employees with sick days, so many go to work ill, with viruses, with the cold, with the flu. These longstanding issues led my friend and colleague, Dr. Kevin Kavanaugh, to write, quote, when COVID-19 knocked on nursing home doors, systemic problems welcomed it. But ultimately, this is more than just an issue with our nursing homes. Western culture in the whole is what we would call Senicidal, which means a genocide of the elderly. The United States has an entrenched problem with our elders receiving poor health care. While Medicare is held up as one of our country's greatest social programs, and it is, decades of cuts and privatization schemes have led to a grim situation. According to a 2017 International Health Policy report by the Commonwealth Fund, Medicare beneficiaries tend to be sicker and forego care more often due to higher costs than their counterparts in Europe and Canada. The report also found that seniors in the US are sicker and more economically vulnerable than comparable countries, yet Medicare is not as generous as comparable insurance in other countries. Those countries also have far less economic inequality than the US. While most of the blame for the savage toll COVID-19 has had on our elders should be laid at the feet of our elected official, our culture is also to blame. Our nation has mostly stood by while a host of preventable healthcare-associated infections, including MRSA and C. diff, kill up to nearly 60% of all patients who contract them. I'm sorry, up to 60% of all elderly patients who contract them. According to the CDC, again, there are approximately 1.7 million healthcare-associated infections annually now and nearly 100,000 deaths. There are many reasons for America's unwillingness to solve our epidemic of HAIs, including a fragmented healthcare system, under-resourced public health systems, and a powerful lobby for nursing homes and long-term care facilities that has largely beaten back attempts to regulate it. Still, I think like COVID-19, if HAIs were killing children or even healthy adults, I think much more would be done. I think we would see much more action. But out of sight in nursing homes or hospitals, our elderly are left vulnerable to these preventable infections. I think nothing captured our culture's disdain for the elderly than certain reactions to the COVID-19 pandemic. From corporate CEOs to pundits to elected officials, in their responses to public health interventions to prevent the SARS-CoV-2 virus from spreading, a lot of our so-called leaders said the quiet part out loud. They claimed that the economic impact of protecting our seniors was too great. They said COVID was just like the flu, which also disproportionately kills older people. Perhaps the most devious statement came from Texas Lieutenant Governor Dan Patrick, who claimed that our seniors are willing to die so we can reopen our economy. But Patrick had it exactly backwards. It is we who have been all too willing to sacrifice senior citizens. We're willing to sacrifice them rather than increase Medicare spending, build excellent public nursing homes and long-term care facilities, invest in senior centers, and ensure that every healthcare facility has stringent infection prevention measures in place. Instead, we deny our role in this, saying, well, it was just his time, or it was really just a blessing. No one said such things to me when my healthy 56-year-old mother died from a C. diff infection. And no one would say anything similar to a parent who lost a child or a young adult who lost their spouse. From a basic moral standpoint, every American should be outraged by the indifference shown in the face of so much needless suffering and death among our elderly population. But even if we're not persuaded by morals or ethics, we should care for a couple of reasons. First, if we're lucky, we will get to be elderly. I mean, honestly, my grandmother in her 80s and 90s was just an amazing part of our lives. And I have an incredible sadness that my mother will never get to be sort of the old matriarch of our family. And with so many great advances in sanitation and hygiene, as well as disease prevention and treatment, life expectancy in America is on average 78 years, and many people live longer. When we are 70 years old and require a minor surgery, we should be able to feel confident that we won't catch C. diff and then suffer for weeks before finally succumbing to it. If we live to be 85 and need to move into a nursing home, wouldn't we want it to be a place that takes protecting our health seriously? Second, beyond our own eventual status as senior citizens, infectious diseases that mostly afflict and kill the elderly also affect the general population. C. difficile was mostly considered a nuisance disease affecting primarily elderly patients. And early on in the 1970s and 80s, it was. And mostly the patients that did get it would get another dose of antibiotics and that would cure it. In 1999, there were less than 800 deaths attributed to C. diff infections, but the new millennium would change all that. Over the next 7 years, the number of deaths would increase eightfold to more than 6,225 C. diff-related deaths in 2006. Again, this is according to the Centers for Disease Control. Despite this surge of increasingly deadly C. diff outbreaks, the disease never captured the attention of the media and therefore the public, as MRSA outbreaks did among younger people, as I mentioned, and among some athletes. You may remember some NFL teams having an issue with MRSA. And then, of course, we had the big Ebola scare and the Zika scare. But none of these infections, particularly Ebola and Zika, had anywhere near the impact on our population as C. diff and MRSA. So under the radar from 2000 to 2014, hospital onset cases alone more than doubled among Americans under age 65 years. So between 2000 and 2014, C. diff cases in people 18 to 64 years of age more than doubled. Now, I can't help but notice that this is also the timeline in which my mother caught C. diff and died. And so to me, thinking about protecting the elderly is also thinking about how do we prevent a situation like my mother's. So while numerous doctors and scientists at the CDC, public health departments, professional associations took note of this rise and did begin to take action on it, there was no effective call to action for the public until after my mother died in 2010 at the age of 65. So now that I've thoroughly horrified and dismayed you, I'm going to offer a path forward. COVID-19 has exacted an incalculable cost from Americans, mostly among our elderly, as well as the poor and working class, who are disproportionately women and people of color. When our mother died, my brother Liam and I promised that her death would not be in vain. As we approach 600,000 deaths from COVID-19, I want each of you to join me in pledging that these losses will not be in vain. This horrible tragedy is also an opportunity to change our healthcare system so we are not caught unprepared for future pandemics. And according to epidemiologists, we will see another pandemic in our lifetimes. How prepared we are to respond to it depends on how seriously we take infectious diseases, starting with how they impact the elderly. Excuse me. So I have 4 ideas that I want to share with you. First, we need to invest significantly more money in public health at the state and federal level. We've seen that happening since the COVID pandemic started, but we need it to be consistent and we need it to even be bigger than what's been proposed so far. So the US spends more money on healthcare, $3.6 trillion than any other nation, yet only 3% of that goes to public health and prevention. When adjusted for inflation, prior to COVID-19, the CDC's budget had remained flat since 2008. So for 12 years, there was no increase in the CDC's budget. In real terms, that means there is less money each year to protect a growing and aging population. And on a per capita basis, we spend just $286 on prevention for each American. Now, if you think about all of the money we pay for healthcare, less than $300 for each American on prevention and public health. According to the Trust for America's Health, most states rely on transfers from the CDC to fund their own public health efforts, which has only just begun to recover from the impact of the Great Recession more than a decade ago. For example, following the Great Recession, local health departments lost an estimated 56,000 staff positions due to lack of funding. Is it any wonder that in the face of COVID-19, states were slow and remain poorly equipped to mount vigorous testing and tracing programs, or that we have had some stumbles in the state level in getting the vaccine out? The Trust for America's Health has an excellent and expansive set of investment recommendations that our elected leadership should implement with all due haste. Similarly, state and city governments should explore how to raise or reallocate funds for their own public health departments. We also need a robust national surveillance and public reporting of all dangerous pathogens. Before my mother died, I naively thought that public health authorities were tracking all the dangerous infections. As a gay man who came out in 1989, I knew that all HIV cases were not just counted, but that sexual partners of the person who tested positive were contacted so they could get tested. So I just assumed this was the case for every infection. And it turns out that I was profoundly wrong. Through a variety of programs, including the Emerging Infection Preventions Program and the National Healthcare Safety Network, the Centers for Disease Control does track a limited number of infectious diseases, but many of these cause less harm and death than C. diff or MRSA. And the CDC is actually doing pretty good. The rest of our nation's public health surveillance and reporting systems are antiquated. In some states, infectious diseases are reported by fax and mail. In an era where I'm speaking to you virtually across every state from my home, and that most of us carry enough computing power in our pockets to broadcast ourselves internationally on Instagram, this is just an unacceptable state of affairs. Now, thankfully, there has been some progress. That might be my dog objecting to the lack of progress, if you can hear her. But thankfully, there has been progress. A program called Data Elemental to Health, which asked to invest $1 billion in 10 years to modernize our public health data infrastructure, was folded into the 2020 CARES Act. This is a great first step, but additional resources are needed to track additional pathogens and to notify people who have been exposed to them. And as again, my friend and colleague Dr. Kavanaugh noted in the article on Infection Control Today, after decades of reluctance to implement a national reporting system in the United States, the COVID-19 pandemic showed us that almost overnight, the formulation of case definitions and comprehensive national reporting could happen from all healthcare facilities. The onslaught of COVID-19 brought about this much needed improvement, and now we must ask, why has this not been done for other dangerous pathogens? A big part of it is that because there is not a infectious diseases lobby. There are not people every day going to Capitol Hill and demanding that we give more money to prevent infectious diseases. We have been working on changing that with many of our partners. So we hope that we will see more progress in the next couple of years. So this is probably the most controversial thing that I'm going to talk about. So I think that when it comes to dealing with lax infection controls in healthcare facilities and nursing homes, we have to embrace mitigation instead of punishment. So the primary penalty for hospitals and not nursing homes yet that fall into the bottom quarter for infection prevention is having their Medicare and Medicaid payments cut by 1%. Now, clearly, I believe that hospitals should be held accountable, and so should nursing homes and surgical centers and every kind of healthcare facility. They should all be held accountable for any lax infection prevention measures that they have and for any outbreaks that occur. But cutting funding, particularly based on infectious disease prevention, which is already under-resourced, can be counterproductive. In fact, the fear of financial penalties can lead healthcare facilities to forego diagnostic testing lest they reveal a high infection rate. It also creates a blame game where hospitals blame nursing homes and vice versa. This does not foster an environment of cooperation and transparency. Worst of all, annual penalties do nothing for the patients and families who are left with the harm or loss caused by preventable infections. They are left to pursue justice through what are often unresponsive medical boards or the civil courts. So rather than see hospitals and nursing homes punished for higher infection rates, we could see them as requiring additional resources and training to mitigate the underlying causes. We could embrace new technologies like ultraviolet disinfection or peroxide disinfection. We can ensure that the people who keep our healthcare centers clean are well trained and well compensated. And we can build a much more robust public health workforce at the federal and state level that can provide the support. So how do we do this? So I think we have to claim our powers that my friend Tara Montgomery, who presented at this summit last year, calls health citizens. So our largely for-profit healthcare system has cast Americans in the passive roles of patients and consumers. And while the Affordable Care Act did some good things, primarily expanding Medicaid to those without insurance, as well as increasing infection reporting, it was insufficient. The ACA also created another level of consumerism, with people comparing plans on exchanges to see if they can get a plan that includes their doctors. It expanded the hospital compare and nursing home compare websites where you can look up facilities to see how they stack up against one another. But the reality is that mostly these choices are an illusion. Facility level data, when it is available, is often several months out of date. So if the situation has gotten better, we may still avoid that facility. If it's gotten worse, we can't know. Moreover, the very coverage we have may greatly limit our options. I know that my health insurance prefers I go to certain hospitals than others. And if we're dealing with a healthcare emergency, we may be taken to the nearest facility with no say in the matter. And maybe we shouldn't have any say in the matter if we're seriously injured. And that doesn't begin to address the asymmetry of information and knowledge between patient and doctor. So all of the talk of consumer choices is just talk. But we can do something different. Rather than view ourselves as consumers of healthcare, as if we were deciding between an iPhone or an Android, we could see ourselves as what my friend Tara calls health citizens. From this perspective, quote, "We are all citizens of a democratic healthcare system. We participate as co-creators, as stewards, and as stakeholders. We exercise our democratic right to provide input into policy, priorities, allocation of resources, and to advocate for the public good. We expect transparency and truthful information. We exercise our social rights, our consumer rights. We believe in progress. We know that we are assets and not liabilities." As we've said before, this is our 6th C. diff Advocacy Summit. Since 2015, we have helped train over 80 people who've had C. diff and lost a loved one to it. We've helped them to step up as the kind of health citizens that Tara is talking about. My mother believed that family and community were vital to our lives and well-being. She also believed in advocating for those who can't do so for themselves. And she believed that knowledge is power. Of all the work that PLF has done since we lost Mom to C. diff in 2010, building this network, this family of C. diff advocates, of health citizens, is the most meaningful to me. In watching the videos that we produced for the summit, which you'll see in between some of the sessions, I got to listen to advocates say they feel part of this community, part of Peggy's extended family. And listening to them brought tears to my eyes. Every time one of our advocates provides support to someone suffering, or testifies in front of a committee, or gets an op-ed published, or, like we're doing tomorrow during our virtual lobby day, talks to their legislators, they are claiming their power as health citizens and part of a growing community and movement. So I just want to leave you with one last thought before we move to Q&A, which is, no matter how many times we consult a WebMD, most of us will never approach the clinical knowledge of a doctor. But as health citizens, we can ensure that the system in which our doctors and nurses operate is safe and accountable to everyone, to the public. As health citizens, we can see the well-being of seniors as not only our responsibility, but tied up in our own well-being. We can ask questions and put pressures on our elected leaders to ensure that we have a great healthcare system and great public health systems. And we can also insist on radical transparency. We can insist that our nation's public health system is well-funded and prepared for pandemics. We can also insist that everyone in our country has access to high-quality preventatives and needed medical care. Only a movement of health citizens can ensure that our seniors are protected, can ensure that our seniors are well cared for, and that by extension, so are we. I would be happy to take some good questions if folks have them. We have about 13 minutes. And to help me answer your questions or ask them of me, I believe Bernie Dias is going to join me.
Hi.
Hi.
Christian, it's truly, truly an honor to work for you. Also having a large family, loving family, I can relate how well deserving the care and attention your grandmother received from you. There are so many seniors who don't get this privilege, but they've earned it. And you're right, we do need to care for our senior citizens.
Excellent. So, folks, if you have any questions for us, let us know.
So it looks like Jose Estrada has asked a question relatable to the U.S. Preventative Task Force.
Okay, yeah. Have we worked with Department treatment? So, Jose, the question to that is we have not yet worked with that particular group. We have been working with our advocates. We have a petition, and we are working on a letter to the new director of the CDC with our goal of having C. diff made a nationally notifiable disease. So you can also check that out on our website if folks haven't signed that petition. But I will certainly look into the U.S. Preventative Task Force. Why not?
Another one asked by Pam McAllister. Are doctors required in any state to report cases? If patients don't enter a hospital, they are tested in office. Do they have to report cases?
So that's a great question, Pam. And to be honest, it really depends. So the Centers for Disease Control has a list of nationally notifiable and nationally reportable diseases. Those are sort of mandated at the federal level. They include a lot of different diseases, but in terms of C. diff, there are states that require the labs to report. So you may catch some outpatient doctors there. But primarily the answer to that is no. Most of the reporting that we do have is based on hospitals. And as I mentioned during my presentation, there's now a lot more voluntary reporting by nursing homes. But in terms of outpatient reporting of infectious diseases, unless it's a nationally notifiable or state level reportable disease, the answer to that is that any particular doctor is not required to report it. So examples of things that do have to be reported are like sexually transmitted infections, like HIV, gonorrhea, stuff like that. E. coli. There's a few that are mandatorily reported, but C. diff is not one of them.
Okay, so I have another question for you. So you delivered the keynote on disposable seniors, and now you've shared the importance on why we need to effectively and compassionately care for our seniors who rightfully earn this credit. You're an excellent and highly skilled writer. Do you think you might write a book?
Okay, I feel like that didn't come from that didn't necessarily come from the audience, Bernie. I think you said it. But so the answer is thank you so much. A little funny aside here. So I minored in poetry writing in college, which my Irish working class family thought was the weirdest thing one could ever do. And then my senior year, I won the Donald G. Whiteside Poetry Award. So I have been writing my whole life, and I actually I have started working on a book that will be a memoir of my mother's life, but also interspersed with what we have learned in doing this work in her memory. So what I'm looking to do is to basically take her values and the things that she taught us as values to live our lives by, and sort of tell those stories and compare them to what we've learned throughout our work with the Peggy Lillis Foundation.
Thank you. Question from the audience. Courtney wrote, "Hello, Christian. Could you speak to the outcomes from the lobby days from previous years? Would be good to know how to build on the momentum that you've built with the PLF of the following days, weeks, and months."
So tomorrow is our third C. diff-specific lobby day, and myself and a few other of our advocates have participated in lobby days that are organized by Pew Charitable Trust, as well as Infectious Disease Society and the Stakeholders Forum on Antibiotic Resistance. So specifically from our lobby days, I would say that we have done a lot of education. Most of the staff that we meet with in the offices of legislators have never heard of C. diff. We had recently done a poll that showed that only 22% of Americans had heard of or were familiar with the term C. diff. So we have a huge issue with a lack of public awareness that also, includes our legislators and our representatives. So a lot of So a lot of education going on at those two lobby days. In 2019, we lobbied quite a bit and spoke to our legislators about that data elemental for health funding that was put together by the Council of State and Territorial Epidemiologists and several other professional societies. As I mentioned, that a portion that got folded into the CARES Act. So we consider that kind of a win. The other thing that we've been successful at is putting stories and faces and names to the kind of funding requests that happen through the appropriations process. So every year, different senators and Congress people will put in their requests for funding to Centers for Disease Control and National Institutes of Health, et cetera. And so what we have seen is the offices of these representatives reaching back out to our advocates and saying, thank you so much for coming in and talking to us. We are voting for the increase that you asked for. So not huge legislative pushes yet, but definitely having an impact in terms of putting the patient face and bringing patients and caregivers to the notice of elected officials.
Wonderful. Thank you.
And how to build on it. We're going to talk about how to build on it throughout this summit, so stay tuned.
Thank you. One last question from Mary. How do we go about getting a great lobbyist? Seems that's the way things happen.
Yeah, it does seem that way, doesn't it, Mary? So I believe very powerfully in grassroots action and organizing. Technically, we do work with lobbyists. You could argue that I spend some of my time in that role and that all of our Advocates Council members do. So in terms of hiring a firm, we do have somebody who's helping us with our lobby day. But ultimately what I think we need to do is to get more and more people invested and aware of C. diff, other preventable infectious diseases, and for them to demand that we have more money for public health. I mean, if you think about just in your own state, when there's a governor's race, how often does public health funding come up in debates, in primary debates? Almost never. So we have to start getting those questions asked at that level. In terms of Capitol Hill, between COVID and having an administration that's, I think, a little friendlier to public health than the previous administration, we do think that we're going to see some good progress. But the other thing I would say is that we don't really need a lobbyist so much as we need a movement. And that's a movement that we've been building, and we want you to be part of it, Mary, and anybody else who's part of this summit. Like, we want you to get involved. And that's the thing that we can do the best, because as we've seen in the past, whether it's the HIV/AIDS movement or the movement for women's health in the 70s and 80s, when you get tens of thousands of people to insist on a change, that's how you get the change. And we're coming close to time, I think, by the way. But do we have any other ones?
I think you've just answered the next question that came about, what can the average person do to help?
Well, that's actually, that's a little bit different. Okay, so let me answer that, and then if we don't have another one, we will give people a couple minutes to use the restroom before the next session. So the average person, the key thing to keep in mind is that your elected officials, even if you didn't vote for them, they work for you and they represent you. And at some point, we made politicians celebrities. And we started to like fight over which one we liked better or something like that. So I would say call your city council member, call your congressperson, call your senator, and, you know, talk to them about C. diff. You know, you can get an appointment. You have every right to get an appointment. And of course, you can also join our Advocates Council, and we will help you and train you on how to do that very, very, very well. So with that, I think we're going to leave it there. And please do join one of our breakout sessions coming up next. We have 2 incredible presentations. One is going to be about the incidence of community-acquired C. diff in people from a lower socioeconomic background. And the other, for those of you who are particularly interested in advocacy, is going to be about an advocacy agenda for to combat superbugs. So there's going to be a lot of people talking about this exact thing there, but both are going to be incredible presentations. So just choose which road you want to go on, and remember that all the sessions are recorded, so you can always watch the other one later on. Thank you, everybody.
Thanks, Christian.
My mother came down with C. diff in 2016, and she suffered from extreme recurrent cases for about 3 years on and off. I would have been about 16, so this is when I was going through the end of high school, on to college. No one in our family had ever heard of C. diff. I remember when she first got the diagnosis, I heard about it through a text she sent me from the hospital bed. And so immediately I had to look up, what is C. diff? How do you treat it? Is it serious?
Marianne Webb spent 3 years in unending pain, hooked up to feeding tubes with frequent hospitalizations.
I watched as she thought that she was going to die, and she got her affairs in order and suffered some really traumatic experiences in the healthcare system. It was a really stressful time and very hard financially to have so many medical bills when she couldn't work to support us. My mother found the Peggy Lillis Foundation through Facebook. She was able to connect with some other advocates and hear their stories to know that she wasn't alone. I was inspired by the actions of my mother and all of the other advocates at Peggy Lillis to become a part of the organization. I met Christian, and I felt like I finally found people who understood what it was like to suffer and watch someone suffer through C. diff. There really is a sense of community there. And so I wanted to become more involved, and I wanted to be a part of making these changes happen, because I do believe that the Peggy Lillis Foundation can bring about real change where it matters.